Have you ever wondered why some women are prescribed aspirin during their pregnancies and others aren't? Well, in this video, I'm going to tell you. In 2018, the American College of Obstetrics and Gynecology published a committee opinion. This was developed by the Committee in Obstetric Practices with collaboration of some members of the Society of Maternal Fetal Medicine. And this committee opinion was reaffirmed in 2023. And the objective was to summarize the evidence and give recommendations on when aspirin should be prescribed in pregnancy. And the conclusion is to prevent or delay the onset of preeclampsia. And what is preeclampsia? Preeclampsia is a hypertensive disorder in pregnancy which is characterized by new onset high blood pressure. After 20 weeks, although the majority are closer to term, with the finding of protein in the urine, and in some cases where there's no protein in the urine, it can be manifested by other signs or symptoms such as pulmonary edema or swelling of the lung, renal insufficiency, low platelets, elevated liver enzymes, and sudden onset headaches without known cause, which is refractory to treatment. Aspirin, also known as salicylic acid, is a non-steroidal anti-inflammatory drug. And without getting into all the details of how it works, the exact mechanism by which it delays or prevents the onset of preeclampsia in high-risk populations is still not totally identified. So, what are the risks of taking aspirin in pregnancy? Well, maternal risks, it hasn't been shown to increase the risk of postpartum hemorrhage or the amount of blood loss during the delivery and the postpartum period, or hemorrhagic complications altogether. How about fetal risks? There have been no increases in the risks of congenital malformations, fetal or neonatal adverse reactions from aspirin exposure. It hasn't been shown to be associated with ductal closure. There has no increase in neonatal deaths from persistent pulmonary hypertension, no increased risk of intracranial hemorrhage or bleeding disorders on the infant. Contraindications of use during pregnancy. And let me start by saying that this should be prescribed by your healthcare provider who's managing your pregnancy, or by the maternal fetal medicine doctor who's managing your pregnancy. The most obvious contraindication would be any allergies to the use of aspirin, or severe allergies to other non-steroidal anti-inflammatory drugs, just because they cross cover, and being allergic to a different non-steroidal anti-inflammatory drug can also make you at risk for being allergic to aspirin. Some women with nasal polyps, the use of aspirin could cause life-threatening bronchoconstriction, so closing of the airways, and should be avoided. And some women have asthma or hypersensitivity on their airways while they take aspirin, so it should be avoided on them as well. When and how much aspirin should be prescribed? Again, this answer tends to be individualized, but grossly should be started between 12 weeks and 28 weeks, and it should be taken daily. The most studied dose is 81 milligrams per day, and it should be taken all the way until delivery, or stopped only if your healthcare provider recommends that you stop. Ideally, low-dose aspirin should be taken before 16 weeks of gestation all the way until delivery. So who should take aspirin? And the American College of OBGYN agrees with the United States Preventive Services Task Force and the Society of Maternal Fetal Medicine, and came with a table showing major risks or moderate risks for developing preeclampsia. And I'm going to write it here right next to the video so you can see them. But if you have one high risk factor or more, you are a candidate for taking low dose aspirin, and you should consult with your physician. The high risk factors are history of preeclampsia, especially if it resulted in a bad outcome, multifetal gestation, that is twins or triplets or more, chronic hypertension, type 1 or type 2 diabetes, kidney disease, or autoimmune disease such as lupus or antiphospholipid syndrome. And then for women that have 2 or more moderate risk factors, the moderate risk factors, it is also indicated for them to take aspirin, and the moderate risk factors are nulliparity, meaning they've never had a baby, obesity defined as a body mass index greater than 30, family history of preeclampsia, a mother or a sibling, and then they list here sociodemographic characteristics such as being African American race or low socioeconomic status, age 35 or older, and personal history factors such as low birth weight, small for gestational age, previous adverse pregnancy outcome, or more than a 10-year pregnancy interval. If you look at the percentage of women that develop preeclampsia who are low risk in the United States, it's between 2 to 4%. Women, on the other hand, that have 2 or more moderate risk factors or 1 or more high risk factors, they have between 8 to 20% chances of developing preeclampsia. So if we were to treat all women with low risk factors for preeclampsia, you would have to treat 500 women to prevent 1 case of preeclampsia, as opposed to treating women that are high risk, in which case by treating 50 we prevent about 1. I hope this information somewhat helps you understand why you're being prescribed or why you're not being prescribed aspirin, or trigger other questions you may want to discuss with your provider. I hope you enjoyed watching this. If you have any questions or would like me to comment on anything more or different, please feel free to do so. Be well, be healthy. Take care.